an assistant professor in the Department of Kinesiology at the University of Wisconsin-Madison. Go Badgers. His work focuses on developing behavioral interventions to treat mental health conditions, particularly depression, through exercise. With a background in both exercise science and neuroscience from St. Olaf College, and advanced training in kinesiology from UW-Madison, Dr. Meyer returned to his alma mater after serving as faculty at Iowa State University. So his presentation today is titled Strength in Mind, Exploring Resistance Exercise as a Therapeutic Tool for Depression. Please welcome Dr. Jacob Meyer.
Hi, everybody. Oh, wow. That's a lot louder. Thank you, Adel, for putting this on. This has been incredible. I definitely can't sum up this as the final speaker, but I will do my best. I really appreciate all the different perspectives that we've gotten so far, especially from questions from folks who have different types of experiences in the community. Sometimes you hear from academics and they talk to you about a laboratory setting, which has no relevance for what you're doing. So I love those questions and I encourage them. I also want to particularly thank Seth for talking about a bunch of the background about depression so that I don't have to in my presentation, which I hadn't even included. So thank you for doing that, even though you didn't know you were doing that. But with all that said, what I'm going to talk about today is one of my major two lines of research, which is looking at resistance training, specifically in the treatment of major depressive disorder. My other research line looks at incorporating exercise systematically into the therapy experience, having people exercise immediately before they start their therapy session. And based upon a bunch of the conversations that we've had here, maybe I should have talked about that instead. But if you have questions about that, I'm happy for us to talk about it later as well. For today, the thing that we're going to, or for right now, the thing that we're going to focus on is thinking about how we might be able to incorporate resistance training specifically into the treatment of depression. Here's what I'm going to go through, thinking about the evidence that exists already for this, then thinking about how it might work, like what are the mechanisms through which resistance training might change the way that we're thinking and feeling, both from the research evidence, but also from the way that people report feeling and using those patient quotes as sort of markers of what might be happening. And then talking about some of the work that myself and others have done so far with some data that I think will be really helpful and might even address some of the questions we've heard before. And then ending not nearly as well as Simon would, but thinking about like where do we go from here? What are the ways that we put this into practice and how do we think about it? So that's what we've got for today. So two meta-analyses that I'll talk about. There's, at this point, hundreds of them that look at all of the different randomized controlled trials that look at exercise and exercise-based interventions to treat depression and other mental health conditions. And so this one, the brain on the left is used to represent that all of these studies for this particular meta-analysis were in adults with depression and looking at how any type of exercise represented by the multiple exercise types on the bottom influences depression. What we see is a very large effect size of 1.11 when you're looking at reducing depression using any type of exercise in adults with depression. But that's nice overall. When we're thinking about what's the right type of exercise to prescribe somebody, we really want to be able to kind of hone in on the different various components. And from this 25 trial study, only 3 of those studies had a resistance exercise intervention. And those 3 studies all had very small samples. So we didn't get a whole lot of information specifically about, is resistance exercise helpful here? And so myself and some other colleagues did a separate meta-analysis that looked specifically at strength training in any adult population in which they measured depressive symptoms across the intervention. And so this could be in people who are depressed, but also in healthy adults who don't have clinical mood concerns. And what we see is across all of those, we still see a moderate effect size improvement in depressive symptoms when we're looking specifically at resistance exercise. So this is sort of helping us build the case that resistance exercise might be helpful. But when we put these two things together, what we see is that there are very few studies, specifically in adults with depression, looking at resistance exercise training. But from the few that we do have, it appears to be pretty powerful. We see an effect size of 1.0, although just 4 trials. All 4 of the trials were very small. But this gives us sort of the idea that, like, we may be, as we try to think about, like, what should we prescribe? How do we get people the best options? Resistance exercise is likely something that we could be using, but we have so little evidence for it compared to the other types of exercise that we typically have. And that makes a lot of sense if we think about how we prescribe exercise. How do we prescribe aerobic exercise? Well, we tell people to walk, or maybe to jog, or to run, depending on their fitness level. And that's pretty accessible. For most people, they know how to do those activities. How do you prescribe someone resistance training? Well, how many sets? How many repetitions? Which movements? Which muscle groups? What's the rest interval? It gets really complicated really quickly. But I don't think that complication is something that we should shy away from, but instead something that we might be able to lean into, and in particular, think about how that might help us in designing the right, or maybe the optimized intervention programs for people. So from kind of like the background of why we're doing this, it seems like resistance training could be particularly helpful, but we don't have enough data yet to really say how or why, or what the right prescription is. So this kind of gives us let's think more about resistance training. And as I look at different types of interventions, I'm always interested in trying to figure out, okay, what's the biological plausibility, or how is this working in the body and taking us from someone pushing against resistance to that person's depression changing? And so we can look at the different neural pathways, different biomarkers of interest. And that's one way to go about it. And that's where I'll start. But then I also want us to think about, like, well, what do people think when you talk to them? How do they experience the exercise itself? And so this slide here is designed to help us look at one of the ways that depression has been thought of to exist or occur in the body. And in particular, when you talk to people who develop depression later in life, or late life depression, there is a vascular depression hypothesis. And this idea, vascular, related to blood flow. In particular, this is related to blood flow in different areas of the brain. The idea here is that there's some either reorganization or restructuring of the way that we deliver blood flow to our brain that ends up leading to depression. Super simplified way of saying that, but this is a hypothesis that has borne out, especially in a number of neuroimaging studies, of showing abnormal brain structure or function or flow, in particular in people who develop depression later, which makes us think, well, if there is sort of a changing of the way that we're allowing blood to flow in our brain, maybe that is something that we should try to fix, and that might help us in fixing the depression. And when we look at the relatively small amount of data that exists in resistance exercise, what we see is that resistance exercise training in healthy adults appears to right the ship in this neurobiological mechanism some degree. So typically, as people do resistance exercise in healthy adults, the cerebral blood flow, sort of like blood flow to the entire brain, improves in velocity as well as in pulsatility in healthy adults. And if we kind of pull all this together, we can say, well, maybe this is how resistance exercise, or RE, is treating depression, but we don't have any data of, does resistance exercise improve blood flow in depression, and is that how we're getting to the improvement in the depression? The fun thing about working sort of in areas where you don't have enough data yet is that you can come up with really good ideas and then you can go test them. And so that's what we've been working on, trying to figure out. Along with looking at the sort of neurobiological mechanistic picture, which is really great. Funders are super excited about trying to pinpoint exactly where depression is. Can we blame it on this specific neuron or this specific area of the brain? But in reality, when you talk to people, they don't care what's happening at that specific level of their brain, right? They care how they feel and how they respond to things. And so in my work, it's always important that at the end of an intervention, at the end of a study, we go and we ask the participants, how did things go for you? What did you see that was positive? What didn't you like? But also, like, how did you feel like things changed in your life? And so these are some quotes that I'm going to show in just a second that are participant reports of how they felt like participating in a resistance training program influenced themselves in their lives. And as you take a look at the three, you can sort of, I've highlighted a couple of the pieces of things that are of interest. First, I didn't realize how much my physical health impacted my mental health. And when I kind of made that connection, like, okay, well, I'm going to do something about it. And the strength training, I think, really aided towards that goal versus aerobic or running. Even, we didn't say like, did you think that this strength training was better than aerobic training? But the participants themselves are sort of bringing up that idea. The second one focuses on their accomplishments. I felt like I could, this challenged me, and I knew that I could do and handle future challenges in the future. And then the third one is also, exercise doesn't just change the way that we feel, it also changes our patterns, our biological rhythms. So sleep improved. You get really tired from exercising, you sleep. People with depression often have a different sort of relationship with sleep, where they either sleep more or less than they otherwise normally would. And this sort of like exercise related sleep regulation is really helpful. When we look across, these are just three quotes that I particularly like, but when we look across all of the different quotes that we get from our participants, they bring up a whole host of different things that they find to be particularly helpful, or ways that they feel like they've improved. And when we look at all of them and then we do an analysis, we can kind of group these together to see a couple of different types of themes emerge. And I think these help us to think about the how or the why exercise might be doing this. And so as we look at a couple of them, the first one, exercise is like fertilizer. And the rest of this quote is like, it's like fertilizer for your brain. It helps you to come out of that period that you've been, maybe ruminating. All of that stuff that's happening in your body and also in your mind. This sort of like hints at the neurobiological things that we're interested in. But further, they're also really interested in the physical health and the sleep benefits. This is more of a, is this actually changing my body, and is that helpful, regardless of where that lives specifically in some region of the brain. And then finally, I think more sort of like psychological or psychosocial benefits are rampant in people's responses. I ended up feeling proud of myself, and I haven't felt that way in years. Well, that's really powerful. It may be more powerful than any of the rest of the stuff that we're doing, right? Those sorts of responses are really key. I feel confident after exercising in a way that I didn't previously. All of this to say, resistance exercise might be helpful. We think that there's a number of different ways that it can work. We can hone in and do some really cool neuroimaging stuff to try to figure out what's happening in the brain, but we can also listen to and hear from patient experiences and learn about what they think is really key too as we go through this process. There's probably a number of different mechanisms that are working simultaneously, a little bit of accomplishment, a little bit of physical health benefits, not necessarily one specific issue. And one of the nice things that Seth highlighted earlier is that there's not one spot in the brain or in the body that depression lives. The tricky thing about depression is that we can't say like, oh, you've got 47 depression protein, you're pretty depressed. We don't have that. And so that also makes it really hard to figure out how do you fix it, because then there's no thing that you can do to reduce that 47 depression protein level. Which means probably that the benefits come from a small amounts or multiple different pathways to get there. All right, well, let's look at some actual data, like what happens when people do exercise and how does that help in various ways. So as we're sort of building the case to try to run a larger study to look at resistance training in particular, we ran a single arm pilot study of a high dose of resistance exercise. 16 weeks of full body supervised resistance training for adults with major depressive disorder who are actively in a major depressive episode. Basically, this was participants who would be good candidates for a new treatment. They might come into their physician and say like, hey, either what I'm doing right now isn't working or a new onset case of depression and interested in a treatment. And so that's the group that we targeted to see if maybe resistance exercise would be helpful. We had them come in and do this program for 16 weeks. They filled out quick inventory of depressive symptoms, their own self-report measure of depression every week across the intervention, and these are the averages that you can see. One of the nice things from our original study was that we just wanted to see, like, would people do this? Are people interested in doing resistance training? And it turns out that the answer from this small group was yes. 90% of people stuck with it. The only person who dropped out of the study moved out of state, wanted to be able to keep doing it, but couldn't since it was an in-person intervention. 98% adherence, that means 98% of sessions were attended, which is incredible for anyone who's ever done any intervention work. You never get numbers like that. And then 93% compliance of, like, did they do what we prescribed them to do on the days that they came in? And we also see this really nice drop in their depressive symptoms as like a side bonus, right? People are interested in it, and it looks like it could be really helpful. And when we break out that data a little bit more, it gets squiggly, but useful, I think. And so if you look at the graph on the left, that's that same figure that we saw previously, except this is every single person is an individual line. And so you can see the individual patient responses across those 16 weeks. Then we also have the red dots, and then follow-up is right after that. And what you can see is that people responded super variably, right? Different people had different responses. But in general, the average response is that blue line. And so you can see across, on average, people are seeing really pretty big drops in those first 4 weeks. And even from week 0 to week 1, we're seeing a sort of an immediate response that appears to be strengthening somewhat over time, and then maybe even a little bit more towards the end of the program. And then the graph on the right is each of the 9 people who we had both pre and post data. This is their change in symptoms from before to the end of the intervention. And so this is like the total benefit that they got from the intervention, right? And what you can see is some pretty dramatic drops. Other than that one person who didn't change a whole lot, everyone else had large, meaningful changes in their depressive symptoms. On this questionnaire, a 5-point drop basically moves someone from one category to another. So from mild to moderate, or from, severe to moderate. And as we're looking, these are decreases. So people are changing 1 to 2 thresholds or categories of depression. So this is really great, right? You're like, cool, that's wonderful. But Jacob, it's only 10 people. So let's fix that. Let's do more. Oh no, wait a second. It's still only 10 people, but I gotta do something else first. Okay, so what we're gonna do here is look at how it's working, right? So I talked about those 4 different ways that things might be happening, and this is the data that we pulled together to look at, in particular, doing some non-invasive imaging of the middle cerebral artery, as well as some other looks at blood flow in the brain. And what we saw here is that as people's depression symptoms decreased, for those people whose depression symptoms decreased the most, that's on the x-axis, the velocity, or the sort of flow in the middle cerebral artery, went up the most. And so it looks like there might be some relationship between the amount of cerebrovascular improvement with the amount of antidepressant response that people are getting on an individual level. So it looks like this could be one of the ways through which resistance training is helping to treat depression. But again, only 9 people here in the end. Looks like this could be how it's happening. It looks generally positive, but we need to really figure this out. So that's when you go hand in hand and you ask a funder for a lot of money, and then they say no, and then you are sad, and then you try it again, and you keep trying until they say yes. And so that's what we did. So right now, I'm in the process of working on this trial. We have a 200-person randomized controlled trial of 16 weeks of either a high dose, so starting at 60% of someone's 1 repetition maximum and then progressively working up, or a low dose, starting at 30% of someone's 1 repetition maximum and then working up. Basically a strength versus endurance resistance exercise training for adults with major depressive disorder. This is that same group of people who are would be coming in and looking for a new treatment. And here's the trial design. We're having people do resistance exercise. We think that's working through some of those changes in brain blood flow, but also through the other mechanisms. And hopefully that's what's leading to clinical responses. A couple of things that I think are worth talking about when you're trying to design a trial like this. In depression, you'll notice that we have either a high dose or a low dose, and then that's the end of our groups. We don't have any more doses or any other controls. And when we're working with a population like adults with depression, ethics get involved in terms of like, what's your control? Are you going to have people not get anything? Is that ethical to sort of like withhold care? Or what's the comparison of interest? And what we were really looking for here is trying to figure out like, does the amount of resistance training really matter for how much better people are getting? Is it that strength and like those sort of related physiological improvements are key, or is just doing it okay? And so we'll sort of have that from before to post in both groups so that we can see how much improvement happens. And then we'll be able to see how important or not important it is between the two groups. The third aim at the bottom, A3, I think is also interesting and relevant to, I think, one of Rebecca's questions earlier, trying to figure out for whom is this the most helpful? And so because we have a large trial here, 200 people, we're going to have really comprehensive assessments on all sorts of things at baseline and then also over time. And we'll be able to say at the end, hey, for these people, they got the best from this. And for these people, they didn't. You know, if you look back at this study, like, can we identify that person on the left who's not going to get much of a response and then give them something else because we want them to get better, right? But we don't know that until the end right now. Hopefully in the future, we'll be able to have created some ways to predict who those people are going to be and then orient what we give them accordingly. Here's the study design for those who are interested. Mostly the information that I think is relevant is to show that it's a 16-week, so 4-month strength training intervention. And we'll have sort of comprehensive mental health data, cerebrovascular function data, and general health data at baseline halfway through at week 8, and then at 16 weeks at the end, and then 6 months, so week 26, and 12 months, week 52. So we'll have some good ability to both see, like, does this help in the short term when someone's in an episode? And then does it help us prevent relapse from happening at those 6 and 12-month time points? Because one of the things that's really interesting and doesn't get captured in a lot of the way that we run trials right now is what happens afterwards. And for any of the clinicians here, relapse is so important to try to figure out. Like, we know that this is cyclical. How do we help people and support them in a way that leads to that not happening as often, or when it does happen, happening to a lesser extent? I don't think resistance training is going to solve all the world's problems, but we need to collect the data to be able to figure it out. So far, here's as far as we've gotten. This is just the flow chart of the trial to date. I ran this on Tuesday, so we have 31 adults currently enrolled in the study out of the 200. Long ways to go. It's going to take a while, but really great participant interest. Tons of people are signing up for it, which is good from like a we need to recruit people, but bad from a I wish there weren't so many people who could benefit from this perspective. But it allows us to hopefully be able to move through this over a little while. If you come back to the Motion Impacts in Motion 6th annual conference, I'll be able to present the data. Okay, great. That all sounds good. We're not at that 6th annual conference yet. So now what? What can we do right now? How do we use this information or the general information that we have? I think putting this into context, as we saw at the beginning, it looks like resistance exercise can be feasible. Seems like it could be particularly helpful for adults with depression. Certainly an option that we should consider for people who might be interested in it. Preliminary evidence is promising. Most people are getting those really large benefits. Hopefully our upcoming trial work will give us a lot of information about how well it works and for whom it works and what the right dose might be. And then it's probably happening through those different mechanisms. The National Institute of Mental Health is very interested in the neurobiology. That's why we have to talk about the brain blood flow piece. But me, as someone who's an exercise psychologist, a kinesiologist, I'm also really interested in hearing what people think is helping them, because in the end, that's really important too. So the recognizing neurobiology, physical health, or psychological health. The article that's up here on the top right-hand corner was published, I think, 2 weeks ago by Nick Fabiano, Brendan Stubbs, and David Puder. And I think is an interesting way to try to keep this conversation that we've all been thinking about here, like very present in people's minds. I rarely would go quite this aggressive, I think, with a title, but could not prescribing exercise for depression be psychiatric malpractice? I think just asking that in the United States might get me sued. But I think it's it forces the conversation to be more relevant. This is an editorial in the British Journal of Sports Medicine, really trying to say like, hey, we know enough. And now that we know enough, is it malpractice for us not to be using it regularly, routinely as part of the way that we go about caring for our patients? I've had some back and forth with Brendan and Nick thinking about what should we do here. I think this overlaps really well with some of the stuff that Simon talked about earlier. A couple of the immediate things, depending on what area that you individually work in, these are things that I think could be helpful. Creating a simplified process to refer mental health patients or people who report initially with a mental health concern immediately to an exercise professional, or at least quickly to an exercise professional. It doesn't have to be the very first thing that happens, but that process needs to be streamlined and simple. Another thing that I've thought a lot about, I did a postdoctoral research fellowship in family medicine. And while I was there, I talked to doctors about exercise, and they said, exercise, cool. But nobody does it. So I don't talk to my patients about it because it's a waste. I only have 3 minutes. And I'm not going to talk to them about exercise because I need to talk to them about the things that are going to happen. And for me, that was really eye-opening because, of course, I drank the exercise Kool-Aid already and was like, wait, you guys are supposed to be helping here. And I think figuring out how we can more systematically into the current and future professionals talk about how do we prescribe exercise in a really simple way in those 3 minutes, or refer very simply for the types of things in which those referrals would be helpful, like mental health concerns of mild to moderate or even more severe cases. I also work with a lot of people in clinical and counseling psychology and trying to think about not just behavioral activation, but also can we think about prescribing exercise specifically in those programs? If nothing else, as Michelle had talked about with recommending 75 to 150 minutes of moderate intensity physical activity for the aerobic side. For the strength training side, just using our national and international guidelines right now appear to be at least sufficient, if not even the best approach for using resistance training to treat depression. Those guidelines are having people do resistance exercise 2 days a week, all of the major muscle groups at a moderate to hard intensity. It doesn't have to be really intense. 2 days a week going through the exercises is helpful. We use 10 total exercises in resist. We have them in machines, using machines rather than free weights, which is simpler and more accessible for lots of people. And it's pretty standardized and relatively simple for people to access. The other thing is creating safe and appropriate spaces for people with mental health conditions, like in gym settings. How do we make a setting that people are going to want to go to? How many of those mirrors should exist? Is the answer 0? Maybe. And how do we recreate our spaces such that that affords the opportunity for other people to be engaged? And I think for me, the biggest sort of take home from all of the stuff that I'm looking at right now is what the entirety of this quote that I showed you earlier actually is. I think we're all going to agree that this is what we want people to get out of our interventions, and trying to figure out ways to do it is important. So I'm just going to read this. I always felt really proud of my accomplishments. So when something challenged me later in the day, it didn't challenge my sense of self. It was just a challenge to face because I had this anchoring foundational experience during that day that said, okay, you're worthy, you build yourself, you're strong, you follow through with all these positive things. And so those were kind of like that foundation. So when something negative came and pushed in, there was something there of substance to resist that. And I think what we want with all of our interactions with patients is we want them to remember that they are something of substance that is in there no matter what. And it's not coming in and working out with me that creates that. That is who you are. But we often lose sight of that. In total, with that, I just want to acknowledge the team that I work with, some wonderful people, collaborators, people here in this room, as well as others elsewhere that allow my group to do the sorts of work that we're trying to figure out. If you're interested in exercise plus cognitive behavioral therapy, I'm happy to answer those questions later. But I just want to say a big thank you to everyone for being here and for listening and for being part of this conversation. Thank you, Edo.
Great. Thank you, Jacob. And